Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to the implications of recent data sets for the current and future management of GU cancers. Today, we're going to focus on the recent ASCO meeting data sets that were presented there. And also keep in mind that today we're going to go for 90 minutes as opposed to the usual 60 minutes. We have a great faculty today, Dr. Rahul Aggarwal from the UCSF Helen Diller Family Comprehensive Cancer Center in San Francisco, Dr. Matt Galsky from the Mount Sinai Tisch Cancer Center in New York City, and Dr. Tian Zhang from the Simmons Comprehensive Cancer Center in Dallas. Today we're going to talk about what happened at ASCO. As in all of our programs, we will be discussing the use of unapproved agents and regimens, so check out the package inserts of the approved agents for more information. Here's where we're heading. Before we get into ASCO, we're going to just take a little bit of a look back into this past year in GU oncology, and of course it goes beyond prostate, bladder, and renal cell cancer, but we'll be focusing on that today. I was thinking about the fact that, July 1st is the new Fellows Day, and I was imagining being a new GU oncology fellow and looking at what's going on in the field. I think really there's nothing like it in all of oncology in terms of the diversity of what's going on, in terms of the strategies that are being used, and also the number of approvals. So fellows, here are just some examples of recent approvals. We'll talk about this AKT inhibitor, capivasertib, already been approved in breast cancer for all, now approved in prostate cancer. We'll see where that fits in. IO, so durvalumab combined with BCG, muscle-invasive bladder cancer. The list goes on. And enfortumab, obviously, enfortumab vedotin and pembrolizumab, a big item. Cell-free DNA with adjuvant therapy, belzutifan in the adjuvant setting. So I kind of put together this graphic just again, before we talk about what happened at ASCO, just kind of reflecting back over the past year. What are some of the things we've been hearing about or we've been talking about in CME programs? We tend to end up talking about new things, and we had a lot to talk about this past year, particularly in prostate and bladder cancer. So I just want to check in with the faculty and see if we got it right. And a lot of these things you'll see in the presentation. But again, just to provide a little bit more of an overview, starting with you, Rahul. One thing for sure, you notice, I guess one thing is the terminology, and, we love working with Andy Armstrong, so I have a hard time remembering the new terminology, but anyhow, metastatic androgen pathway modulator, naive or sensitive, what we used to call hormone-sensitive metastatic disease, Rahul. But now we have a real, algorithm-based approach. You're going to talk about a lot of this data, PARP. We mentioned AKT with capivasertib and also lutetium, radiopharmaceuticals up front. And then, of course, what we've been seeing the last few years is that intensifying endocrine strategies, or ADT, just keeps moving earlier and earlier, all the way up to the Proteus trial. Any comments, Rahul, on these trends and how much of an impact do you think it's having on quality life of patients as well as mortality?
Yeah, I think it's a great question. This is a great summary. I think what we're seeing is all these agents which showed activity initially in the hormone-resistant or APMR setting are clearly showing a large magnitude of benefit, potentially larger magnitude of benefit as we move them earlier. We saw that with the ARPIs. We saw that with docetaxel. I think we're now seeing that with the targeted therapies like the PARP inhibitors and radiopharmaceuticals. Proteus is a great example of going even earlier into the perioperative setting. So a lot of excitement and enthusiasm about moving these agents earlier.
So, Matt, also another thing that's kind of been interesting as we see some agents are moving out of one subspecialty or one type of cancer into another. I listed a bunch of thoughts about urothelial bladder cancer, but including there, and we'll talk to you about it in general, but I just want to ask you about what point I made here with anti-HER2 and TDXD. We also have tisotumab vedotin. It's very exciting data. But it also brings up the issue of the fact that, for example, TDXD was approved first in breast cancer, and they really have a lot of experience with breast cancer in terms of how to use it, preventing acute GI toxicity. And so we've actually had breast cancer investigators speaking sometimes by video in our programs at AUA, for example, last night, actually, we did a program on AKT inhibition with Drs. Hope Rugo and Virginia Kaklamani. You may know Virginia is the head of the San Antonio Breast Cancer Meeting. And the whole program was on AKT inhibition. And they spent a lot of time talking about how they use capivasertib. They feel like there's a lot of granularity about how to use this targeted therapy. Just kind of curious, Matt, what your experience has been. Again, I guess TDXD would be a good example, kind of learning from the other subspecialties how to use agents. Any thoughts, Matt?
Yeah, it's funny that you mentioned that because I picked up one of the tips in terms of managing trastuzumab deruxtecan toxicity or monitoring for it, rather, from one of your programs. I had heard one of the breast investigators talk about the timing of when they do their first SCT and adopted that into my practice. So I think there's a ton that we can learn by listening to others who have more experience using these agents. There's a learning curve there.
Another thing, when I look at this list, and again, I can imagine a GU oncology fellow looking at a list like this. A couple of things I thought was kind of interesting is, one, I don't see chemotherapy on the list, which kind of tells you a little. You see that throughout oncology, moving into ADCs or other options besides chemotherapy. And the other thing that we hear in other tumor types I haven't heard too much about is cell-based therapy or T-cell directed therapy, either bispecific, CD3 bispecifics, or CAR T therapy. But Rahul, I did notice that there actually is a CD3 bispecific that is being studied in prostate cancer. There were a couple of trials in progress papers presented at this ASCO meeting of phase 3 trials, I think, looking at this bispecifics. This is maybe one example where T-cell therapy is maybe going to come into being. Anything you want to say about this, Rahul? And, one of the concerns here is cytokine release syndrome. We saw a CD3 bispecific introduced in small cell, but these people seem to do pretty well. Any thoughts about whether bispecific or T-cell based therapy is going to come to prostate cancer, Rahul?
Yeah, I'm quite excited about the T-cell engagers. I think we finally crossed the threshold to see some success with immunotherapy in prostate cancer, and I think pasritamig is a great example of that. It seems to have a very favorable safety profile, a very low rate of CRS. It's given fully as an outpatient every 6-week dosing. And so this on the screen is one of 2 phase 3 trials that are underway with pasritamig, and really excited to see the data come out.
So, Tian, any thoughts about cell-based therapy, CAR T, and renal cell cancer? Any new strategies in renal cell that you're excited about?
Well, we've seen a couple of approvals on the last slide with belzutifan in the refractory space, as well as with pembrolizumab in the adjuvant space. CAR Ts wise, we've seen a couple of small phase 1-2 trials with CD70 CAR T based therapies. Unfortunately, a lot of toxicity without a lot of efficacy. So I think more to come on this kidney cancer front for cellular therapies.
So coming back to urothelial bladder cancer, Matt, of course, one of the biggest stories in oncology, period, is EV-Pembro. The idea of an ADC and IO is not just here. We see this in breast cancer. Currently, first-line therapy is an ADC and IO, sacituzumab govitecan, the TROP2 ADC plus pembrolizumab. This past year, we saw this incredible data in the localized setting, neoadjuvant, post-neoadjuvant, but even in metastatic disease, looking like there's maybe a tail on the curve here, even in the metastatic setting. Any comments on that? And also, maybe as a related issue in the localized setting, the use of ctDNA, of course, colorectal cancer. This has been a big, this is really part of standard of care, but it really exploded this past year, starting at the last ESMO meeting with the IMvigor study, looking at that. So any thoughts, Matt, about my list here? We also have intravesicular therapy. I'm really fascinated by the TAR 200 or 210. We're going to talk a little bit about that, the so-called pretzel. And then, as we just went through, the recent approval of immunotherapy, in this case durvalumab, up front with BCG, non-muscle invasive disease. Wow, so much going on here. Matt, any thoughts?
I think you got the list right. I think if I was a fellow who was going to specialize in GU medical oncology, then I would study this list and look at these trends and try and understand the data that supports these making the list of the hot topics for this year. I think each one of these is really a major improvement in the treatment of patients with urothelial cancer. I guess if I were to have to pick a quick comment on one, I think it's probably worth noting that the approval of durvalumab in patients with BCG-naive non-muscle invasive bladder cancer, probably the earliest clinical disease state of any cancer for which there's approval of a systemic immune checkpoint inhibitor.
Yeah, that's a great point. I didn't even think about that. You're absolutely right, and really interesting. So then also renal cell cancer, Tian. I was fascinated by this adjuvant belzutifan study that was presented. I actually had a chance to talk to Dr. Motzer about it and get his thoughts. He's very excited as well. But there is some controversy, and we're going to get into that. Of course, we're talking about not just belzutifan, but belzutifan with pembrolizumab. So really the standard has been when adjuvant therapy has been used with renal cell, it's been pembro up to now. But now we have the option of pembro's belzutifan. We also saw pretty interesting data with belzutifan in the relapse setting after IO therapy. I think we're going to see another negative study in the future and near future looking at upfront in the metastatic setting. But we'll talk about this adjuvant situation. Leanne, any thoughts about this, and what have you been hearing from your colleagues about it? Are people ready to go? Are they reserving this strategy for younger patients? Is it something that at this point is at least a discussion point with people in the adjuvant setting?
Sure. Well, PIF2 alpha inhibition has been a topic that really has manifested now in belzutifan's approval in multiple disease settings, as you've outlined, in the refractory setting as a monotherapy, now in the adjuvant setting combined with pembrolizumab. So very exciting. But sometimes, we're thinking about who are the right patients to treat. How should we go about finding those patients who really need treatment in the adjuvant setting? So certainly, to your point, it is a bit of a patient selection for those patients who are at the highest risk of recurrence, and trying to avoid toxicity for patients if they're never going to recur, avoiding the added toxicity. So I think still not a lot of biomarkers to help us figure out who's destined to be that high risk for recurrence, where we really need to intensify adjuvant therapy.
So we just want to sort of set the stage before we get into what's happening at ASCO, and now we're going to do that as well. As we go through this, we also ask the faculty to provide cases from their practices, so we're going to briefly hear about a number of patients here tonight and try to get a little bit into not just the data, but what it means in terms of taking care of patients. So we're going to start out now with Rahul. Let's talk about what happened at ASCO, of course, including a plenary presentation as well. So Rahul, take it away.
Great. Thank you, Neil. Yeah, happy to present the updates from ASCO on prostate cancer. We're really going to talk about androgen pathway inhibition in EPMS, or hormone-sensitive prostate cancer, some of the novel triplets, and updates in targeted radioligand therapy as well. So we can get right into it and really focus first on the androgen pathway inhibition in hormone-sensitive disease. We have a plenary session presented by Mary Ellen Taplin, the phase 3 Proteus study, some updates from EMBARK, study in biochemical recurrent prostate cancer, and then a really interesting study of treatment interruption that was presented by Atish Chaudhry called A-Dream. And so we'll cover all of these abstracts. But let's first start with a case. This is actually a patient of mine I saw in the context of a multidisciplinary clinic along with urology and radiation oncology. This is a 64-year-old gentleman actually presented with an elevated screening PSA of 16.4, previously had been normal, no significant urinary symptoms, had high-grade disease on his TRUST biopsy, Gleason 4+5. You can see a representative image from his staging PSMA PET. He's got uptake there in the prostate, not shown on the slide, but also had uptake in small bilateral pelvic lymph nodes as well. This patient opted to receive ADT plus ABI plus PRED for 24 months in combination with radiation to the prostate and pelvis as per extrapolation from the STAMPEDE phase 3 study, but really thought-provoking question now that we have the Proteus data, which we'll present in a second. Could we think about multimodal perioperative systemic therapy with radical prostatectomy, particularly for the younger fit patients that might want upfront surgery?
So before you go on, just kind of checking in, thinking about this patient, 64, kind of to me on the young side. I'm curious, thinking about him as a person and how he was viewing his treatment, and also how you feel about the Proteus data. Do you think if you were to see him today, if you could, you would present Proteus as an option? And do you think you would have taken that option?
Yeah, we're still waiting on the regulatory decision with Proteus, but I do think for younger fit patients, particularly those that have either node negative or have small pelvic nodes on PSMA PET, I think upfront perioperative therapy with radical prostatectomy is a very compelling option based on the Proteus study, and you'd want to be able to present both options to a patient so they can make a fully informed decision.
There's so many situations in oncology where we say at least discuss it with the patient. If they want to be involved in the decision, great. If not, that's fine too. But I think at this point, it's going to have to be, particularly once it gets approved, be discussed. All right, let's talk about the data.
Exactly. Yeah. So this is the study schema for the Proteus study. It is the largest study ever conducted in the localized prostate cancer setting. So this is an over 2,000 patient study. Patients are randomized to either placebo or apalutamide plus ADT. Both arms did get ADT in the perioperative setting. So 6 months of therapy before and 6 months of therapy after radical prostatectomy. Strat factors are shown there, and the co-primary endpoints were PAT-CR/minimal residual disease, as well as metastasis-free survival, which was defined by a composite of either PSMA or conventional imaging. You can see the imaging schedule shown there on the right as well. These were the primary results from the study. So the co-primary endpoints on the left, you can see there was a significant improvement in PAT-CR MRD rate, 8.9 versus 1% in the control arm. So an odds ratio of 10.17. And then the second primary endpoint of MFS by either conventional or PSMA PET imaging, the efficacy threshold was met. The hazard ratio here was 0.8, so a 20% improvement in reduction in risk of metastasis-free survival with apalutamide versus placebo. Here are the safety results from the study. I think that it's fair to say there was no significant new safety signals. There was a higher rate of grade 3 or higher adverse events related to apalutamide. You can see the breakdown of those adverse events on the right. Nothing surprising there. Skin rash is a known toxicity of apalutamide that patients and providers do need to manage. There was a slightly higher risk of treatment-related deaths, 7 versus 1. Mainly cardiovascular, and there was some cardiac safety monitoring that was implemented during the course of the study.
Before you go on, and this is such an important study, I'm curious what you're hearing in your colleagues and locally, how you're discussing this and thinking through. Is the thinking that the benefit that's seen here is worth whatever downside is involved? And what about the strategy of using preoperative endocrine therapy? I don't know how much has been done in the past. How do you think that's going to sit with urologists?
Yeah, it's a great question. I think for your appropriately risk stratified, very high risk localized patients that might otherwise get ADT plus ARPI plus radiation currently as per STAMPEDE, I think it's very reasonable and appropriate to offer perioperative therapy with radical prostatectomy. And I think the risk benefit profile is acceptable there. We've obviously had many prior trials of ADT neoadjuvantly leading up to radical prostatectomy that have not shown this degree of benefit. So I do think the doublet therapy here is important.
So one of my favorite trials for the last 5 years has been the EMBARK study, and it just keeps on giving great information. Can you talk a little bit about what they looked at, what they saw, and what we're learning about it as time goes on?
Absolutely. Yeah, also a really huge effort in the biochemical recurrence setting. The study was conducted prior to the era of PSMA PET imaging, but nevertheless a very important study. High-risk biochemical recurrence, PSA doubling time less than 9 months, really innovative design in which there's 3 arms, actually, enzalutamide monotherapy or the doublet versus ADT control arm. And importantly, this study allowed treatment interruption after 9 months of therapy in patients that had a PSA nadir that was less than 0.2. And that was really the focus of the update at ASCO this year. before covering that, these were the primary results of the combination arm versus ADT alone, and really quite striking data that Steve Friedland presented at ESMO last year is not just improvement in metastasis-free survival, but look at that hazard ratio for overall survival, 0.6 for the doublet versus monotherapy. And these are patients that stopped therapy after 9 months of treatment and then resumed once PSA started to rise again. So stemming from that, really one of the important questions from a patient quality of life standpoint as well, what happens during that break? And about 90% of patients actually were able to take that break after 9 months of therapy. And a third of those patients actually recover their testosterone to greater than 250 with a median time to recovery of about 6 months. And that was the data that was presented at ASCO this year.
So one of the things I love the most about the EMBARK study is they really brought in the issue of intermittent therapy that had kind of been discussed in the past, and I don't know if people were really sure what to do or how much data, but it really seemed to be an effective strategy. You're showing here time to testosterone recovery in these patients. The other thing that was a little confusing, you kind of alluded to it before, is that now we know most of these people probably would have been diagnosed with metastatic disease if they'd had PSMA scans. What do you do with patients who are only PSMA positive, for example? In the old days, so to speak, which just a few years ago, they would have been called biochemical only. Any thoughts about that dilemma?
Yeah, it's a great question. I think about this a lot, and you sort of think about the median PSA at entry of EMBARK was around 4 to 5. So yeah, majority of these patients, the vast majority, would have PET positive disease. But if you think about it, this really reaffirms that even in those low volume metastatic patients by PSMA PET, doublet therapy is still important, and that's where you're really seeing the survival benefit. And it brings up, as you said, this treatment interruption possibility, and that when you have an optimal PSA nadir, you can safely stop therapy and then resume at the time that you think is clinically appropriate.
So, covering all of oncology, we a lot of times bring up the EMBARK study when we talk about other, for example, in CLL, they talk about time-limited therapy, and we go, well, yeah, they've been doing that in prostate cancer for a while. So really interesting. The other thing about this study is they had an arm which did not have ADT. It was just enzalutamide alone. Again, when I first saw that, I was thinking, well, that might be a good option for people who were concerned about ADT side effects. But I'm not hearing from investigators or even docs in practice that they utilize it because I guess the benefit of the combination was so striking.
Yeah, that's right. I mean, enzalutamide monotherapy showed an MFS benefit, but no overall survival benefit, and the magnitude of that MFS benefit wasn't as striking as the doublet. And there are still side effects to contend with enzalutamide monotherapy, higher rates of gynecomastia and so forth. And so it's definitely a trade-off.
So what about this A-Dream? We were talking about intermittent therapy. There's another paper from ASCO. Can you talk about that?
Yeah, this is really an innovative design. This was led by Atish Chaudhry. It's actually an Alliance Cooperative Group study. This is a phase 2 study that's now formed the backbone of phase 3 trials that are really testing this concept of intermittent therapy. We know from the older days of just ADT monotherapy, intermittent versus continuous therapy in the metastatic hormone-sensitive setting was not shown to be non-inferior with long-term outcomes. But now that we have combination ARPIs, we have PSMA PET imaging to reopen that question. So this was a study in patients that had an optimal PSA nadir, less than 0.2, 18 to 24 months after starting their therapy for metastatic disease, really looking at could you safely stop therapy, and then what was that treatment-free interval with a recovered testosterone to greater than 150 at 18 months from the stop of treatment. That was really the primary endpoint of this study. And it really did meet its primary endpoint. This is a little bit of a busy slide, but over a third, 41% of patients were treatment-free 18 months later with a recovered serum testosterone. So there's really good proof of concept data that has lended itself to the phase 3 trials underway.
Just kind of curious, in your own experience, when people come off ADT and endocrine therapy and then their testosterone recovers, do they feel better? They feel different? Can you see it?
Absolutely. Sometimes we can even tell before the testosterone recovers on their lab report because they'll start to say, hey, doc, my hot flashes are starting to get better and I feel like I have more stamina when I'm going to the gym. So absolutely, there's a quality of life benefit here.
So really a benefit there in terms of quality of life as well as length of life. How about these triplets? This is really getting very complicated now, at least in my mind.
Yeah, complicated in a good way. I think we're really starting to get beyond just disease volume and timing of metastasis to really think about molecular biomarkers and guiding our treatment. And so this is a slide I put together as part of the ASCO discussion last year, but I continue to update it as we get more clinical trial data. And we'll cover 3 abstracts, the capivasertib trial, the TALAPRO-3 study, and also prior data from the Amplitude trial that was presented last year. So first, before we do that, just coming to my second case, this is a patient, young gentleman, 57-year-old patient of mine, presented about a year ago with obstructive urinary symptoms, low back pain, very high Gleason score on his biopsy, had molecular profiling with both a PTEN deletion and TP53 mutation, had IHC staining that showed loss of PTEN expression in 95% of his tumor. Very high volume. You don't need conventional imaging to tell you that by PSMA PET, this is clearly a high volume patient, primary tumor, hepatic, pulmonary, and bone metastases. This is a patient that, based on Capitello 281, we might think about Capi, wasn't yet FDA approved at the time. We treated with a triplet with docetaxel plus ADT plus abiraterone. Patient's actually done well with an optimal PSA nadir less than 0.2.
So before you go on, just kind of curious, do you think if he were to present today, you would have used capivasertib and not docetaxel? And what about the strategy? I've heard this discussed as well, as giving the docetaxel, giving the triplet, and then if they have a suboptimal response, then adding in the capivasertib.
Yeah, it's a great question. We get that question a lot. It's unfortunately not the way that the trials were designed in terms of, routinely allowing that docetaxel and then giving in suboptimal nadir. I think you have to present the choices, and I think this would have been an option for this patient. I'm still tempted, I have to say, to give docetaxel to these patients, particularly when they have loss of dual tumor suppressors, P10, P53, sort of suspect that there may be some antigen-independent component to his tumor. And so I'd still be tempted to give docetaxel, but Capi would certainly be an option as well.
So another thing that came out, and you're about to go through the Capitella data, but just to precede that, I really wish I had asked the docs last night about breast cancer, because I'm not sure about breast cancer. But one of the other things that came out when this trial was presented was sort of the natural history of these patients with PTEN deletion, as presented by Dr. Fizazi. First, a much poorer prognosis, just a conventional therapy, much earlier relapse. But the other thing was that they seemed to have progression with not necessarily with the PSA up. It might be imaging only, which affected how you think about following these patients. Is that something that people commonly had observed? Have you observed that before? And how did just that basic knowledge affect the way you manage these patients and whether or not you even get the test to start with?
Yeah, it's a great point. Yes, so for patients that have high-risk genomics, so 2 or more loss of tumor suppressor genes, P10, P53, certainly if RB1 is in that mix, high Gleason score relative to a relatively low PSA. These are patients where I'm getting cross-sectional imaging every 3 to 6 months. I'm not just trusting or relying on the PSA. There are definitely circumstances where you can get radiographic progression without a rising PSA. You're going to want to biopsy those patients and look for if there's any neuroendocrine transformation.
So let's take a look at the data. I was curious whether the FDA was actually going to approve it or not, although we were thinking they probably would, but we weren't really sure. But of course they did. So let's talk about it.
Absolutely. This was a study schema, so a very large study. It took over 6,000 patients to be screened. About a quarter will have PTEN deficiency by IHC. So this was not a genomically selected group. This was based on protein staining. 90% or more loss of tumor PTEN expression was the qualifying criteria. 1-to-1 randomization, it was placebo-controlled. Investigator-assessed rPFS was the primary endpoint. You can see the strat factors there. The data that were presented by Dr. Fizazi last fall were really the primary analysis of rPFS. The OS data are still immature, but you can see the data here. The rPFS did meet its pre-specified endpoint, so the hazard ratio was 0.81. You can see that in the Kaplan-Meier. I'll just call out that, as you alluded to, the median rPFS of the control arm with an ADT RP doublet was 25 months. So from the time of start of therapy, only 2 years until you have radiographic progression. So it just highlights that this is a high-risk group of patients. This is a clinically insignificant, statistically significant improvement. OS is still immature. You see a trend towards potential OS benefit there. And just looking at this, I thought were some of the most interesting data from this study. It's really a spectrum of PTEN loss, and the deeper the loss of PTEN expression, the greater the magnitude of benefit. So this is an exploratory analysis, but actually a consistent result across all the efficacy endpoints that were looked at. You can see that for the subset of patients with 100% loss of PTEN, you can see the hazard ratios there, much deeper benefit. I think this may inform clinical practice, even though it's an exploratory analysis. And as you showed earlier, we just received FDA approval for this triplet combo on June 12th.
Do you think most labs are tuned in to doing this IHC assay quantitatively? As you point out, it looked like there was a big difference in terms of whether they were 90% or 95 or 100%. Is that something that's right now available in most places to give that kind of data?
Yeah, not routinely available. Even this biomarker, it is a companion biomarker. It's still in the process of being rolled out with different labs like Foundation and others. So I think it's a specific antibody clone that's used for the IHC testing. So I think there's still lots to learn about the clinical implementation and what kind of data we expect to receive.
So, of course, the other issue here is tolerability. We've learned that just because therapy is targeted doesn't mean it doesn't have tolerability issues you have to deal with, even if it's an oral agent. This one also has a different, administration, 4 days on, 3 days off. As I mentioned, the breast cancer people have their whole thing about how they prevent toxicities like rash and diarrhea. Also, hyperglycemia. We were talking a lot about that last night, a lot of variation in that. These trials had hemoglobin A1C restrictions. Well, we talked about the issue of using continuous glucose monitoring that's commonly used now in diabetes. To me, when this was first presented at ESMO, I was hearing from a lot of GO investigators, there were a lot of concerns about using CAPI. They were very, kind of concerned, let's just say, about the toxicity there. Where do you see things now? I mean, I think the docs in practice who've used it in breast cancer will probably be a lot more comfortable than GU investigators. What are your thoughts, and what are you doing in terms of preventing toxicity and managing it, Rahul?
Yeah, I think we have a lot to learn from our breast oncology colleagues, because I think this is definitely a new paradigm. We haven't really had anything targeting the PI3 kinase pathway before. So I think patient selection is going to be key. These studies did have entry criteria based on A1C, but I'd say we may need to be even more stringent in clinical practice. We're going to have to work with patients, primary care providers, maybe even endocrinologists to really fine tune the glucose management for patients that are treated with this triplet.
So we actually had a CME program earlier on ophthalmologic issues in oncology. We had cardio-oncology and all, and now ophthalmologic. Then we did a program on glucose issues, hyperglycemia across oncology. And we were talking about these drugs in particular. And one of the things we had an endocrinologist on there brought up was, trying to tune the patient up, so to speak, in terms of maybe using GLP-1 drugs, trying to get their hemoglobin A1C down even before they get started with treatment. So more and more oncology is becoming truly multidisciplinary.
Absolutely.
So let's talk a little bit about another biomarker-based addition to the hormone-sensitive disease, PARP inhibition.
Yeah, absolutely. And I think, this is just a slide that demonstrates that there may be some synergistic rationale for combining an AR pathway inhibitor with PARP inhibition. And of course, in that first line mCRPC setting, we have 3 positive phase 3 trials, Magnitude, Propel, and TALAPRO-2, that have all showed a benefit, particularly and most deeply in the BRCA1, BRCA2 mutated tumors. That's led to FDA approval of these 3 combinations. You can see that listed on the chart here. I think what's gotten folks really excited is moving this concept of ADT plus PARP earlier into the hormone-sensitive space. And this was a TALAPRO-3 schema was presented by Neeraj Aggarwal at ASCO this year. HR-altered mCSPC, placebo-controlled trial, Tala at 0.5 milligrams plus enzalutamide. RPFS investigator assessed was the primary endpoint. You can see those primary results on the top left. Very impressive hazard ratio, less than 0.5 for the investigator assessed RPFS. This was even deeper when you look at the BRCA2 mutated patients. So just a huge gulf between those arms if you look in the top right. Less strong of a magnitude of benefit in non-BRCA HR, but there's still a benefit. And I think one of the most striking things here was the forest plot of the individual genes to see that there's potential benefit with CDK12, CHEK2, et cetera. The numbers are small, the confidence intervals are wide, but really intriguing with this combination. These are the adverse events shown here. I think this is important as we move these PARP inhibitors early. Patients are exposed longer. Long-term hematologic toxicity monitoring, I think, is going to be critical. The grade 3 anemia rate in this study seemed to be comparable to what we've seen in other trials, but it's really the long-term toxicity monitoring that's going to be important here. Just want to briefly cover Amplitude. This was presented last year at ASCO 2025. Very similar concept, but with abiraterone and niraparib, rPFS with a primary endpoint. You can see that BRCA mutated patients had a much deeper benefit than the other HR altered tumors. And this really led to FDA approval of specifically in BRCA2 mutated MHSPC. This is a combo that's now FDA approved as of December of last year.
So just to chat a little bit about PARP inhibitors first, and now, the importance of doing not only genetic testing, but also somatic testing, particularly looking for BRCA, and also the fact that for some reason, you see much more BRCA2. You hardly, I guess, very rarely see BRCA1, and very different than breast cancer. Any comment on where we are in terms of testing in the so-called real world, Rahul? Do you think the message is out there?
I think the message is out there, but these are upfront newly diagnosed patients with metastatic disease, de novo disease. And so I think it's still going to take even further effort to really underscore the point that both somatic and germline testing are important. I see a lot of patients that have had one or the other, but not both. And I think we do need to still further push that message out there.
Any comment on tolerability issues, both acute? Of course, we started talking about PARP inhibitors, particularly with ovarian cancer, and got a lot of experience there in the maintenance setting, looking at the issue, particularly hematologic issues like anemia, thrombocytopenia. There was an issue about AML and MDS. Seemed like less of an issue, at least in ovarian, with earlier use of the agents before a lot of chemotherapy, but also quality of life issues about nausea and vomiting. So as you mentioned, it's been out there in the relapse setting for a while now, up into earlier stage disease where it's going to be used for longer. Any comment about how you see patients with prostate cancer responding and tolerating PARP inhibitors?
Yeah, I think two comments. One, for the short-term toxicity, generally it occurs early. So you have to check the blood counts frequently every couple of weeks. If there's going to be higher grade anemia, you'll know it early. You can interrupt, the counts recover, you can safely restart at a lower dose. So that's an effective strategy. And then secondly, yes, there is a long-term risk of MDS, AML. Our patient population is older, higher rates of baseline MDS or CHIP. So I do think the safety monitoring is going to be important. And if there's persistent cytopenias, you have to think about a bone marrow biopsy for that patient.
We were talking about GU fellows. I was thinking about just oncology fellows starting out in oncology a couple of weeks ago, watching this thing, taking notes furiously. Like it's a lot to digest. And let's get to the next one now. We have another issue here, which is lutetium.
Radioligand therapy. Yeah, absolutely. This is an exciting area, and this also moving earlier. And so this is updates from the PSMA addition study. But before we get that, I'll cover my third case. This is actually a patient with APMR, MCRPC, taxane-naive prostate cancer, originally presented 2024, had Gleason 5+5 prostate cancer, very high risk. PSA was 50, bulky adenopathy, received a triplet, ADT, Abi, docetaxel, had a suboptimal nadir here, 0.7, subsequently transitioned in a relatively short time frame to MCRPC. Had a biopsy, as we often want to do in these higher risk patients, was still adenocarcinoma, did not have any neuroendocrine staining, had good uptake on a PSMA PET scan, and actually started lutetium in the pre-taxane, so the PSMA4 type setting in March, and really it's had a wonderful response. So we at our institution get SPECT CT scans after each dose of lutetium. So you can see on the top is pre-treatment. This is a very bulky RP node. You can see very SPECT avid. And then after just 2 cycles of treatment, really has had a complete response. There's no residual uptake in that node. So very impressive.
So I don't know, Tian and Matt, whether you're sort of jealous of radioligand therapy or whether you think maybe it'll ever come to your tumors of this really impressive response. What do you see in terms of tolerability, Rahul? I've heard about dry mouth. Do you see cytopenias? It seems like it's a very favorable tolerability profile.
Yeah, I think head-to-head versus cabazitaxel, no question, quality of life was better with lutetium in the castrate-resistant setting. I think in the hormone-sensitive setting or earlier MCRPC, I think what we often do is use adaptive dosing, where if a patient has an excellent response like this, we'll stop, we'll follow their scans and PSA, and that really helps mitigate toxicity. But in general, it seems to be a quite tolerable treatment. Dry mouth, typically fairly low grade. As we get into actinium and some of the newer isotopes, we'll just have to see how that toxicity manifests.
How are people responding? Oh, go ahead, Tian. Go ahead, please.
I was just going to say, we are seeing such nice responses with PSMA lutetium. One thing I would note, and Rahul alluded to it, is that the responses are not always durable. And so sometimes as patients then progress, there are some that are being re-challenged. And I think really tailoring it for the degree of PSMA uptake is spot on, Rahul.
Yeah, that's a great point.
I'm curious, Tian, what are you hearing your colleagues saying? Or what are you talking about in tumor boards about the possibility of doing? We're about to talk about the PSMA addition trial, now moving this up into the hormone space that, as you can see, is very crowded. What are you thinking about whether you'd want to do this or not, and in what situations, Tian?
I think it really depends on PSMA avidity. We're across our hormone sensitive spaces. There's a lot of options, and we don't have the approval yet. But PSMA addition was a positive trial read out last year, and so if lutetium comes into that space, it's really thinking about who has those very bright SUV means over 10. That might be the right patient to treat with lutetium compared to the other options that Rahul just outlined so nicely.
That's really interesting. I haven't heard anybody make that point, but it really makes a lot of sense. Rahul, how are you processing it? Would you like to be able to use this strategy right now? Would you have used it in a patient like this patient up front if you could have?
Yeah, I think Tian raises a great point. Instead of thinking of PSMA PET as a binary positive, negative, it's really a spectrum. And the more avidity, the more likely it is you're to see benefit. And you could define that different ways, but it's a little bit of that eyeball test and reviewing with radiology. And yeah, you have a very PSMA PET avid patient. I'd happily give them this triplet as opposed to a taxane triplet in the hormone sensitive setting.
All right, let's talk a little bit about the data.
Yeah, absolutely. So these are just a summary of these are previously published and presented data of the two trials of lutetium 617 in the MCRPC setting. On the left was PSMA4 in the pre-taxane. On the right, post-taxane, the VISION study. VISION, no question, there's an overall survival benefit. PSMA4 allowed crossover, so over half of patients in the control arm did receive lutetium, and that definitely confounded the OS benefit. When you adjust for that, you do see a significant benefit. And of course, this led to FDA approval of lutetium in the CRPC setting. I think we're excited to see what happens in the hormone sensitive setting. This was the schema for the PSMA addition trial. 6 cycles, so standard dosing in PSMA PET positive hormone sensitive disease. Dealer's choice ARPI doublet control arm. And, we've seen the primary results of this study. That was the RPFS on the top left. What Fred Saad and colleagues presented at ASCO this year was really the subgroup analysis looking at low versus high volume, de novo versus recurrent metastatic disease. Take-home point, generally you see a consistent benefit across these clinically defined subgroups. And then just finally finishing up on some really interesting data with actinium 617. So alpha particle, shorter path length, higher linear energy. This was a trial with a drug that was given every 8 weeks for up to 6 cycles. It was a dose escalation and expansion study. You can see the 3 different groups defined based on their prior therapy. Appear to be pretty well tolerated. You do tend to see pretty high rates of dry mouth, xerostomia. Don't see a huge amount of cytopenia, so pretty good tolerability, did not reach its MTD. And really impressive PSA waterfall plots, including in the prior lutetium group, which that's group C on the bottom right. See the majority of patients have a PSA decline. We'll have to follow patients longer to really understand duration and RPFS and so forth.
So, Rahul, what's the thinking in terms of how this actinium and lutetium are going to sort of be factored in? It kind of reminds me of some of the discussions I hear about ADCs. Is it going to be the target or is it going to be the payload? This is maybe a little bit different. Can you see using both of these radio-labeled agents in the same patient, and what kind of sequence?
Yeah, that's a great question. I think what's going to come first is we already have lutetium so well established. And there are phase 3 trials of looking at actinium PSMA in the post-lutetium setting. And we already know from retrospective studies that the drug is active. So I guess that those studies are going to be positive. But there are trials underway really asking the question of should we be giving actinium first? And there are studies including an ACT First clinical trial that's really looking at this question of bringing actinium first and comparing to a dealer's choice control arm. So we'll have to see how it evolves.
So we're going to move on now and talk about urothelial bladder cancer. And again, I'm thinking about these GU oncology fellows going to the prostate clinic one day and then maybe the next day going to bladder cancer. So here they've just heard all this stuff about prostate. Well, here it comes even more. Urothelial bladder cancer, really amazing, Matt. So amazing for us to be in CME thinking about what we used to talk about 5 years ago and now what we're going to talk about here. So let's go through the data. You have your cases at the end. We'll talk about them, but let's talk about the data first.
Okay, so let's talk first about non-muscle invasive bladder cancer and really the earliest trials that we've seen immune checkpoint blockade, really in any disease, but particularly or specifically in bladder cancer. So here's 3 phase 3 studies that tested the same concept. Should we add immune checkpoint blockade to BCG for patients with BCG-naive non-muscle invasive bladder cancer? The trials were designed very similarly with a few nuances. So we have Potomac with durvalumab, Alban with atezolizumab, and then Crest with sasanlimab. And we have 2 of 3 of these studies meeting their primary endpoint. And in fact, the effect size for Potomac and Crest was identical hazard ratio for event-free survival. Potomac, we've seen an FDA approval for the combination of durvalumab plus BCG. Crest, we haven't seen a regulatory decision on yet. So we have an approval of immune checkpoint blockade in patients with high-risk non-muscle invasive bladder cancer. Here's the Potomac overall survival data that was presented at ASCO. Of course, with patients with BCG-naive non-muscle invasive bladder cancer, we don't necessarily expect to see a survival benefit with an intervention. And here you see survival is pretty similar between the 2 arms. The other key piece of this presentation, though, was quality of life data. Again, these are patients with very early stage disease getting an intravenous systemic immune checkpoint inhibitor, and you want to understand how that impacts their quality of life.
So I'm curious how you're seeing this play out in your practice and with your colleagues. Of course, IOs and non-muscle invasive disease have been out there for a while in terms of BCG resistant. Now we're moving it up earlier, but as you say, I mean, IOs do have toxicity. Type 1 diabetes, you can have serious toxicities from IOs, and a situation where theoretically you have cystectomy as sort of a backup. People, I guess, are bringing up the issue of how much benefit, how much long-term benefit. How are you seeing your people and in your own clinic, Matt, sort of processing this in terms of clinical decision-making?
So this is early days, just recently approved by the FDA for this regimen. And what I would say is the theme that seems to be occurring, and this is analogous to some other situations in oncology. One, we have a lot of intravesical therapies that have been introduced for the treatment of non-muscle invasive bladder cancer, but most of those are currently in the BCG unresponsive setting. And now we have a regimen in patients with high-risk BCG naive disease. And I think what we're seeing is patients with very high-risk features, for instance, a patient who presents with high-grade T1 disease, maybe that's a good patient for an aggressive upfront approach, knowing that you potentially have these other intravesical therapies to use in the future.
All right, well, let's talk about the pretzel, so to speak, another really exciting, unique development. I mean, this whole scene, particularly from the point of view of a medical oncologist, I think a urologist may be more tuned in to non-muscle invasive disease, but medical oncologists now need to be involved in at least understanding what's going on. What about TAR-200, Matt?
Yeah, so we talk a lot about drugs as medical oncologists, not a whole lot about engineering, but this is really an engineering feat. So this is an intravesical delivery device. It's a small catheter that assumes a pretzel shape when it's inserted into the bladder, so it stays in the bladder. It can be impregnated with drug. That drug is slowly released over time to achieve better exposure within the bladder. Remember, when we give BCG, when we give intravesical chemotherapy, a catheter is placed, it's clamped, patients hold it, and then they urinate that drug out. And so there's very limited contact with the urothelium, very limited exposure. This is meant to overcome this. So really two versions of this so far. One is with gemcitabine in this device. The other is with erdafitinib, the FGFR3 inhibitor in the device. So let's talk about some of the data. The most robust data that we have to date is for TAR-200, the device with gemcitabine in patients with BCG unresponsive non-muscle invasive bladder cancer with carcinoma in situ. And we know from the Sunrise 1 study, a single-arm study of TAR-200 in patients with BCG unresponsive CIS, that the CR rate was 82.4%. That's among the higher CR rates we've seen with some of the recent generation of novel intravesical approaches for non-muscle invasive bladder cancer, and many of those responses have been durable. And so this is really a new strategy for BCG unresponsive disease. And then I'll mention TAR-210. This is FGFR3 inhibition, erdafitinib in the pretzel. We know that patients with non-muscle invasive bladder cancer, particularly low-grade, low-stage disease, have the highest prevalence of FGFR3 mutations among the spectrum of bladder cancer. So it makes a lot of sense to target FGFR3 in this patient population. TAR-210 was explored because erdafitinib given systemically, given orally, was shown to have really nice activity in patients with non-muscle invasive bladder cancer, but it's a drug with systemic exposure limited by side effects.
So, yeah, we've heard a lot of stories about systemic erdafitinib and the challenge of using that. When I heard about this, putting it intravesicular, it sounded really fascinating. For practical purposes, how much does it complicate things to use the TAR-200 or 210 device compared to other intravesicular approaches, Matt? And what's your take for practical purposes about where this is fitting in?
So TAR-200, from my urology friends who insert this, tell me it's a relatively straightforward to learn how to do this. It's changed TAR-200's changed every 3 weeks initially and then less frequently over time. TAR-210 every 3-month treatment. And so despite the fact that this needs to be inserted into the bladder and retrieved, given less frequently than some other therapies, and so convenient from that standpoint. There are some patients who have some sense for the device intact in some symptoms, but for the majority of patients, it's a really well-tolerated intervention.
All right, let's talk about, I guess, really one of the biggest stories of all, oncology, EV-Pembro.
So EV-Pembro has really transformed the way that we treat patients with bladder cancer. Of course, initially data in the metastatic setting, and I'm going to show some of the longer-term follow-up data from the EV-302 study. And then, of course, this combination has moved earlier into the perioperative setting with 2 randomized phase 3 trials, which I'm going to speak about. Before getting there, just adjuvant therapy with immune checkpoint blockade as monotherapy, because that really preceded the EV-Pembro data in the perioperative setting. We know from the Checkmate 275 study that nivolumab in the adjuvant setting, Checkmate 274 rather, nivolumab in the adjuvant setting is associated with improvement in disease-free survival approved by the FDA. We also know that not everyone needs adjuvant therapy because some patients are cured with surgery, and we need biomarkers in the setting to define who needs treatment and who might be appropriate for surveillance. And so ctDNA, circulating tumor DNA, that's tumor-informed MRD assays, has really made a huge impact in this clinical disease state in bladder cancer. And we have the first study establishing clinical utility for ctDNA testing in the adjuvant setting with IMvigor11. This randomized patients, this study enrolled patients after cystectomy with high-risk features. Patients had ctDNA testing using the Signatera assay. If their Signatera was detectable, they were randomized to adjuvant atezolizumab versus placebo. If their ctDNA was undetectable, then they were monitored with serial ctDNA testing. That study showed an improvement in disease-free survival and overall survival with adjuvant atezo versus placebo, and really showed that in both patients who started treatment right after surgery with detectable ctDNA, or if that treatment was started later in patients who developed molecular conversion from undetectable to detectable assays. Of course, quality of life in this setting also critically important. At ASCO, we saw quality of life data from IMvigor11, and we did not see any detriment in quality of life with adjuvant atezolizumab versus placebo in this setting. Checkmate 274 really showed the same thing, and so adjuvant immune checkpoint blockade for patients with high-risk muscle-invasive urothelial cancer overall does not seem to lead to a detriment in quality of life, important in the adjuvant setting.
Maybe before you go on and before you get into EV Pembro, just another point in terms of ctDNA. I don't know, maybe it's, now there's always been the issue of whether or not to use preoperative therapy or not. I'm not sure that everybody was getting it prior to now. Now that you're about to show the data with EV Pembro, you would imagine a lot more people are going to be getting neoadjuvant therapy. So first of all, for people who don't get neoadjuvant therapy, who are presenting in the adjuvant setting, is this paradigm being embraced by investigators of really using ctDNA to decide about adjuvant therapy? And do you think that ctDNA is going to become part of the paradigm even as EV Pembro moves in, that maybe the post-surgical after neoadjuvant ctDNA, or even in metastatic disease, that ctDNA is going to become a part of either localized or metastatic disease or both?
I think it's becoming integrated into patient monitoring, and it's a data point in decision making. But I think right now there are a couple of caveats. One caveat is that there was no randomization in patients on IMvigor11 who had undetectable ctDNA right after surgery to immediate adjuvant treatment versus surveillance with treatment upon molecular recurrence. So we do not know that a watch and wait approach is necessarily non-inferior yet. And so a little bit of caution in that regard. The second caveat, of course, is that that paradigm was based on patients who had not received prior immune checkpoint blockade. And now we have two neoadjuvant regimens, EV Pembro and Gemcis durvalumab, where patients have already received neoadjuvant immune checkpoint blockade. And so the implications of that ctDNA test after surgery are not the same. And of course, we can't extrapolate that IMvigor11 data to these new regimens. So yes, I think it's going to be done, but we don't have the data necessarily to rely on the test as a sole basis for treatment decision making.
All right, well, let's talk about the use of EV Pembro in the the perioperative setting. Again, I think one of the big developments in oncology, period, over the past year.
So the first study to read out with EV Pembro in the perioperative setting was in patients who are cisplatin ineligible. That's the KEYNOTE-905 study. Remember, previously there was no standard neoadjuvant therapy for patients who are cisplatin ineligible. There was no data suggesting something other than cisplatin-based chemotherapy was beneficial. So KEYNOTE-905 randomized patients between EV Pembro in the perioperative setting, that is both before and after surgery, before and after cystectomy, versus cystectomy alone. There was a third arm with Pembro alone. That's how the study started. Pembro followed by cystectomy, followed by adjuvant Pembro. That arm we don't have data on yet because it closed early in favor of enrolling patients to the EV Pembro arm. This showed an improvement in event-free survival. Overall survival led to FDA approval. We have a similar study called Volga, with durvalumab plus EV, followed by cystectomy, followed by adjuvant durvalumab alone versus cystectomy alone. And then there's a third arm integrating tremelimumab. We've seen a press release that this study is a positive study too, both EFS and OS in the durvalumab plus EV arm, EFS in durvalumab trevi plus EV, but not OS in that arm yet. So really interesting observation, and we'll have to see the details when the data is presented. Keynote 905, we saw additional data for at ASCO this past year. And again, we're seeing this theme of these major phase 3 studies read out, being presented this year, and then following that, a lot of quality of life data being presented. And on the one hand, the quality of life data is all reading out pretty similarly, and that these novel regimens are not leading to a detriment in quality of life, which is clearly really, really important data. It's been seen though across each one of these studies, and that's been a theme of conferences the past year. So Keynote 905, no clear detriment in quality of life with EV Pembro versus patients who went to cystectomy alone. The other set of studies that we've seen are in patients who are cisplatin eligible, and we saw the Keynote B15 study with EV Pembro in the perioperative setting with cystectomy versus Gem-Cis neoadjuvant therapy and cystectomy. That study also demonstrated an improvement in event-free survival and overall survival. Just recently led to an FDA approval, and this is now a standard treatment for cisplatin-eligible patients. And we saw at ASCO some additional data from the Keynote B15 study, including a first look at biomarkers. Of course, the question comes up all the time, should we use PD-L1 testing? Should we use Nectin-4 immunohistochemistry to select patients for EV Pembro? As you can see in the forest plots, there was no clear difference in patients with high versus low PD-L1 expression or high versus low Nectin-4 expression for the effect size for perioperative EV Pembro versus Gem-Cis in the neoadjuvant setting. Finally, we saw EV Pembro follow-up data in the metastatic setting from EV302, and these are really quite striking data. If you look at the tail that seems to be forming on this curve later in follow-up, if you look at the percentage of patients who are alive at 3 and 4 years with metastatic disease, quite impressive, and then really, really quite impressive. We know that about 30% of patients have a clinical CR with this regimen in the metastatic setting. And if you look at the likelihood that a patient will be alive who has a CR 3 years later after starting this regimen in the metastatic setting, above 90%, really quite striking data.
So we've been thinking a lot about the tails on the curve in IO studies, particularly when we saw, believe it or not, an extensive stage small cell where there was a median survival of 13 months, but there still was like 12 to 15% of people who were out at 5 years. And of course here that looks even more impressive. So Tian, another issue that's going throughout oncology, obviously, is ADCs. I think maybe there was a thought originally, hey, this is not going to be as toxic as chemotherapy. I'm not sure that we've seen that, but what we have seen is a lot different toxicity than what you see with chemotherapy. I'm curious, now we're talking about using an ADC in the perioperative setting, but in general, what you've seen with EV in terms of tolerability, side effects, preventing them, managing them, how difficult or easy has it been, and what about, again, in the localized setting?
Sure. So with EV, we talk a lot about rashes, hyperglycemia, neuropathy, and in our patient populations in the metastatic setting, we're often dose reducing early. If patients have baseline neuropathy, I'm not hesitant to dose reduce. In the perioperative setting, I think in that curative intent, I much more would rather start them at full dose. And here, either the 3 cycles for cisplatin ineligible patient populations for EV303 or the 4 cycles for EV304 we can get patients through most of these 3 or 4 cycles without too much difficulties. Now, we have certainly seen the rashes come up even after 1 or 2 cycles. So educating patients about what they might see early on can help them, be aware and alert us when these even early rashes occur. Often they're responsive to topical steroids. The neuropathy really comes on in our practice after about 6 or 7 cycles. And so hopefully in the perioperative settings, we're not seeing as much of the neuropathies after 3 or 4 cycles.
So, Matt, in a second, we're going to get into your cases, but a couple of things from the chat room here. First of all, Hassan wants to know, when would you de-escalate EVP in the advanced disease setting? And Padma has a case that she'd like some input from you on. Cisplatin-eligible patient, stage 2 muscle-invasive bladder cancer, gets treated with the Niagara regimen that you were just talking about, has a complete pathologic response, and she wants to know, would you continue the Durva as planned? Would you do ctDNA testing to help guide whether to continue it? And I've heard the questions like that in triple-negative breast cancer as well, but what about here, Matt?
So I guess the first question first, de-escalation of EV-Pembro, I think you have to take that on a case-by-case basis, and it's based on the degree of response and the type of toxicities that someone's developing, and in trying to balance those in an optimal way. So that needs to be individualized. With regards to continuing treatment after the Niagara regimen based on a PATH-CR, so we know based on the PATH-CR data that there, of course, patients have better outcomes who have a PATH-CR that don't. We also see maybe a sliver of difference between the curves in patients who got adjuvant immune checkpoint blockade versus those who didn't. And so it's hard to know whether or not that's the quality of response from the neoadjuvant portion or if the adjuvant portion is driving that at all. But in the absence of any prohibitive toxicities, that's the way that the regimen was given to yield a survival benefit, and I would stick to that regimen.
All right, let's take a quick look at your cases, Matt, starting out with this 68-year-old man. What happened with him?
So this is a 68-year-old man, former smoker, presents with gross hematuria, has a cystoscopy, diagnosed with high-grade T1 disease. He has a restaging TURBT because you always want to make sure that this is not a muscle-invasive bladder cancer. So he has a repeat TURBT. He has persistent high-risk non-muscle-invasive disease, no muscle invasion, no metastatic disease. So this is a patient with high-risk non-muscle invasive, BCG unresponsive, non-muscle invasive bladder cancer. This patient was treated with BCG. If I saw this patient today, then the Potomac regimen is one of the regimens that we would discuss in terms of the potential for added benefit.
You said one of the options. What other options might you be thinking about?
Versus BCG alone.
Oh,
So
interesting.
BCG alone, or yep.
All right, let's hear about your second case. This is a 74-year. Whoops, sorry, getting a little bit.
Yep.
There you go. 74-year-old lady.
So this 74-year-old woman who presents with urinary symptoms, diagnosed with a bladder tumor, clinical T3 disease. A scan shows no evidence of metastatic disease, has a creatinine of 1.8. So this is a patient who is cisplatin ineligible with clinically localized muscle-invasive bladder cancer, and this is a patient who met the criteria for Keynote 905, was treated with perioperative enfortumab vedotin plus pembrolizumab, and had a pathological complete response to treatment.
So another issue that I hear a lot of people talking about is avoiding cystectomy, and we're seeing some, really effective neoadjuvant therapy. Any thoughts about where that in patients who are otherwise eligible for cystectomy, whether or not in the future maybe they're going to be offered the option to avoid it?
So the PATH-CR rate on Keynote B15 and Keynote 905 was 57 and 58%. We know that if everyone proceeds with cystectomy, then the majority of patients will have no cancer left in their bladder. And so that really raises the hypothesis of whether or not transurethral resection plus systemic therapy could be curative. There's been a series of studies trying to establish that approach in a stepwise and thoughtful manner, but the data the data is still limited. The sample sizes are small, single-arm studies. We are now just seeing the initiation of larger phase 2 studies and even 2 phase 3 studies testing that concept. So we have EV209, a large single-arm study of EV Pembro with response-guided bladder sparing. That is, if there's a clinical complete response, no cystectomy. We have HCRN GU22598, a slightly smaller study testing the same concept. We have EV309, randomizing patients between that approach and concurrent chemoradiation. So we will see definitive data in the next few years for that approach.
So certainly radical cystectomy is one of the most morbid procedures done in oncology. It'd be so great if we could try to avoid that in some patients. How about this last case? We were talking about cell-free DNA. And it seems like also tumor-informed cell-free DNAs like Signatera seem to be what people are using in these perioperative situations. What happened with this 71-year-old man?
So 71-year-old man presents with hematuria, diagnosed with muscle-invasive bladder cancer, declines neoadjuvant therapy, goes straight to surgery. He has pathological T3N0 disease and has detectable ctDNA after surgery. So this is clearly a patient who should receive adjuvant therapy. We know from large retrospective data that the risk of metastatic recurrence is incredibly high, and we now have established clinical utility for adjuvant immune checkpoint blockade in this setting. And of course, we know that nivolumab showed a benefit in disease-free survival in an all-comer population in this setting. So this is a patient who should and did receive adjuvant therapy and received immune checkpoint blockade.
We actually did a poster at the ESMO GI meeting on a survey we did of GI investigators of the use of cell-free DNA, mainly Signatera in colorectal cancer, and it's not available in Europe. When we wanted to present the data because it's really becoming standard of care. All right, let's move on now and talk about renal cell cancer. Again, I'm thinking about these fellows furiously on 4 pages of notes at this point. But Tian, let's talk about some of the data that came out over this past ASCO meeting.
Sure, great. Glad to talk about kidney cancer data. So we'll start with adjuvant kidney cancer and talk about some of our circulating tumor DNA data. We'll move into LightSpark 022 and then talk about Rampart and highlight a trial in progress. So just as a reminder, the Keynote 564 trial was the registrational phase 3 trial for pembrolizumab in the adjuvant setting for high-risk kidney cancer. At ASCO this year, we saw the first circulating tumor DNA analysis from Keynote 564 using both a 16-plex and a 64-plex circulating tumor DNA detection on those samples that they had. What we'll notice in these samples is that circulating tumor DNA positivity, the sensitivity is harder to detect in kidney cancer populations. So about 30 of these patients in each of these cohorts treated with pembrolizumab and placebo were actually positive for circulating tumor DNA after they had had nephrectomies. And for those patients with positive ctDNA, though, their prognosis was quite poor compared to those patients who remained ctDNA negative. And the sensitivity of the 16-plex assay is even worse than the 64 assay. And so I think when we're thinking about ctDNA, if their patients are getting these in practice after nephrectomy, the patients that have positive disease are certainly a high-risk patient population. And when you use pembrolizumab for those patients, they tend to shift the curve up if we have seen in some of the other data that were presented at ASCO this year. Wanted to highlight LightSpark 022. This was a trial in the adjuvant setting that was presented at GU ASCO this year. This is the registrational phase 3 trial for a combination of pembrolizumab with belzutifan, the HIF-2 alpha inhibitor, compared to a year of pembrolizumab. And the primary endpoint was disease-free survival by investigator. These are the patient characteristics for the patients who were randomized. You'll notice a majority were non-U.S. Patient populations with intermediate and high-risk disease. There was about 9% of patients with M1 NED population, so those patients with metastacectomies of a single or oligometastatic disease. And disease-free survival was improved with pembrolizumab and belzutifan in the intention to treat population. The overall survival did not really differ between these populations, but this did result in an FDA approval in mid-June for the combination of pembrolizumab with belzutifan in the adjuvant setting. Just a note on the treatment emergent adverse events. When we're thinking about these patient populations, certainly when we're adding in belzutifan, anemia is an on-target effect of inhibiting HIF-2 alpha, as well as some more grade 3 fatigue and some elevated LFTs that are not seen as much in the pembrolizumab and placebo-treated cohorts.
So, there's been a lot of debate about the use of adjuvant pembro to start with, and now we have this option of the doublet, Tian. I'm curious how you see, again, your colleagues processing it. It seems like maybe at least it ought to be brought up to the patient, and I'm not sure, you think about it more with a younger patient, for example. Can you talk about how people are processing it? Also, when you see a lack of survival benefit, some people pull back a little bit in the adjuvant setting. How do you see your colleagues and how are you, at your local institution, people thinking about this?
Sure. I think it's, finding the high-risk patient, certainly the M1 NED patient who might be at higher risk for another metastatic recurrence, or the ctDNA positive, if that's part of their routine practice to send circulating tumor DNA with the Signatera assay afterward. Any positive assay there would put the patient at higher risk. I do think, when we're in practice and seeing these folks in the post-op setting, we're often talking about recurrence risk, and so we rely a lot on the Assure nomogram, the Leibovitz score, and thinking through recurrence risk with that patient in front of us based on their own clinical and pathologic features at the time of surgery, and then helping them make a shared decision. In some cases, younger folks, as you say, are very motivated to get adjuvant treatment. They want to delay or prevent recurrence as long as possible, regardless of the overall survival changes. Maybe some patients who are older are more inclined to think about, life differently and really weigh the toxicity element in a little bit more. So certainly a moment for shared decision-making in our clinics.
So it's really almost breathtaking to think about the difference in all the different types of therapies we've been talking about today. And here we have a whole completely different toxicity profile. I'm curious again, obviously this has been used in recurrent disease, or we saw a paper that you're going to comment on with lenvatinib, but hypoxia and anemia is not something you think that much about outside of this, and yet these are pretty major issues. I'm curious how it's playing out. There was also, I think, a paper at the GU ASCO about using this drug at high altitudes and whether that's going to be more complicated in terms of hypoxia. How do you think about it, and what do you say to patients in general about to begin belzutifan, whether it's in the adjuvant or metastatic setting?
Absolutely. We often counsel to get a mobile pulse ox so that patients can monitor their own oxygen saturations at home. This is an on-target effect. So if they do have early hypoxia, something that worth noting and wanting to potentially dose reduce or correct that as we can, but particularly patients who live at higher altitudes. For the anemia, anemia, we're watching that in clinics. We're adding erythropoietin in as their hemoglobins fall below 9, and really being proactive and helping patients mitigate the anemia.
Yeah, Dr. McKay was telling me she goes ahead and puts the order in for the ESA when they start treatment in case they're going to need it, because sometimes it takes a while to actually get it. So I was surprised, given that how commonly Ipi/Nivo is used in the first-line metastatic setting, that it didn't seem to play out in the adjuvant setting. What about this Rampart study that it looked at, one of the arms looked at Durva/Tremi, but how about this, and also just the issue of Durva here?
Sure. This is an investigator-led trial from Europe of durvalumab with tremelimumab, a combination versus durvalumab versus active surveillance in the post-nephrectomy setting, in the adjuvant setting. And so we also saw this data at ASCO this year. Disease-free survival in the intention to treat population was improved from active surveillance to either treatment cohorts, but not much difference, as you see in those curves, with durvalumab versus durva with tremi. And here's the overall survival. I would make the comment that overall survival is harder to see a difference in all comers in the post-nephrectomy setting, mostly because these patients hopefully do very well, have a long time that occurs before overall survival, their death event that factor into OS endpoints. And so if we're not seeing overall survival differences, that's possibly a very good thing in the adjuvant setting. And then I would just want to highlight the STRIKE trial, which is the only adjuvant trial that is actively enrolling across the U.S. This is a trial that our colleague Brad McGregor leads in the Alliance Cooperative Groups, randomizing patients to either pembrolizumab alone or the combination pembrolizumab with 6 months of tivozanib, which was one of our VEGF TKIs that's approved in the advanced settings. So if people are interested in being on a trial, this is the one to consider in the adjuvant setting. And we'll move on to the metastatic setting. We'll talk a little bit about CheckMate 9ER as well as CLEAR, and then move on to the refractory disease with LITESPARK-011 and TiNivo-2. So first-line metastatic kidney cancer trials, the phase 3 designs, the common cohorts was sunitinib, and we had 6 phase 3 trials that have all read out that have led to our current practice patterns in frontline metastatic disease. We'll just highlight CheckMate 9ER and CLEAR as they had data updates at ASCO this year. CheckMate 9ER being cabozantinib and nivolumab, and CLEAR being the combination of lenvatinib and pembrolizumab. The 9ER subgroup analysis, these is patients with bone metastases. You're seeing progression-free survival on the left with bone metastases on the top, without bone metastases on the bottom, both favoring cabozantinib with nivolumab over sunitinib, and then overall survival on the right, again, bone metastases on the top, without bone metastases on the bottom. Maybe some greater differences in the curves for the patients with bone metastases. And certainly we know patients with kidney cancer and bone metastases have a poorer prognosis in general, and so these patients certainly need their IO doublets early on. These are the patients with hepatic metastases that were presented at ASCO this year, and again, you're seeing differences in both progression-free survival and overall survival, particularly for patients who have liver metastases on the top curves that you see there. And then finally, CLEAR had some updated data sets on outcomes based on patterns of progression. So they took patients in the metastatic setting and stratified them with low risk progression of disease as growth of existing lesions, intermittent risk disease as being new lesions, and then high risk progression as new lesions and growth of their existing lesions. And what you see is that patients with low and intermediate progressive disease had more favorable overall survival, the 2 curves on top, compared with the patients with their high risk new lesions and growth of their existing lesions, that curve on the in green. In addition, low-risk progressive disease had more time on next-line treatments as compared to those patients who developed new lesions. And then finally, we'll come to refractory disease. There are a couple of trials, LIGHTSPARK-011, combining lenvatinib and belzutifan for post-IO treatment in refractory metastatic kidney cancers compared against cabozantinib. And then the other trial that's currently enrolling is PEAK-1. This is a separate HIF-2 alpha inhibitor called casdatifan, combined with cabozantinib compared with cabozantinib alone. And so we saw data of LIGHTSPARK-011 at GU ASCO this year. This is the trial schema of patients who had progressed after prior PD-1, PD-L1 treatment, either in the frontline or second-line therapy. So no one was past third-line treatment. And these were their patient characteristics at baseline. What we saw on the primary endpoint of progression-free survival was that lenvatinib and belzutifan improved PFS compared with cabozantinib. Overall survival certainly trended toward improvement. We haven't seen the full overall survival benefit quite yet. We also saw at ASCO this year the follow-up of TiNivo-2. This is also in the refractory setting of tivozanib with nivolumab compared against standard of care everolimus. And here we saw follow-up progression-free survival and overall survival outcomes between these two patient populations. And then finally, there was a trial in progress that's ongoing called LIGHTSPARK-033. This is combining belzutifan with zanzalintinib. This is a shorter-acting cabo, if you will, but patients in the refractory setting randomized 1-to-1 to either the combination of belzutifan with zanzalintinib versus cabozantinib monotherapy. And then final data set that we'll present is on non-clear cell kidney cancer with cabozantinib and nivolumab. This was presented at ASCO this year from our friend Darren Feldman and his colleagues. And so this was an investigator-initiated trial that we've actually seen a report of previously. This was their follow-up in a bigger cohort of 53 patients. And when they saw their objective responses was about 43%, another stable disease in 51%. So certainly cabozantinib and nivolumab have disease activity in these patient populations, in particular for the FH deficient types of papillary kidney cancers. And the safety events were not necessarily different than what we've expected with hand-foot syndrome, diarrhea, hypertension, et cetera, when we're managing patients on cabozantinib and nivolumab.
So let's finish out with your cases here. It looks like this is an adjuvant situation and pretty big tumor there. Maybe thinking about this new combination with Pembro and belzutifan. What happened with this patient?
Sure, a young guy, 58 years old, 11 centimeter mass, had his right radical nephrectomy with clear cell kidney cancer, Fuhrman's grade 3. Post-op labs were beautiful. He was very interested in adjuvant treatment. We talked a bit about pembrolizumab, Pembro-Bel, and our trial Strike that's actively enrolling. He opted ultimately to start pembrolizumab alone.
How's he doing?
Great. Got his first cycle 2 months ago.
How about this 68-year-old man who got cabo-nivo?
This patient had presented with systemic symptoms, quite symptomatic, a 14-centimeter mass, a de novo metastatic disease. He was anemic. His platelets were high. So he had higher risk disease, IMDC risk. So he started cabos with nivolumab. And at 9 months, his lung nodules have resolved. He has a stable left renal mass. And we just would remind folks that, patients who have large primaries in place, they don't necessarily get to a complete response in their primary tumors. So setting those expectations early on is important. There is this ongoing question of when to consider consolidative nephrectomy. And so, this is an ongoing conversation with urology. We don't want to wait until the primary mass starts growing again and starts becoming resistant to our system. systemic therapies. So in our shop, it's been anywhere from 6 to 12 months. I know there are some practices that like to wait a little longer, but certainly something that is reasonable to consider if patients have achieved a really good systemic response in outside of the primary.
Anything new in terms of choosing between Ipi/Nivo and TKI/IO?
I think, when we're thinking intermediate poor risk disease, all the IO doublets are great candidates. In that particular patient, we chose the VEGF IO, particularly because he was so symptomatic with high risk disease.
Let's hear about the 62-year-old man.
Sure, and refractory disease. So this patient had a nephrectomy 3 years prior, developed lung metastases. You see his nephrectomy path there, clear cell type. He represented with anemia and intermediate risk disease on IMDC criteria. He started Ipi/Nivo, and 6 months later on the maintenance portion of nivolumab alone, he develops new liver metastases. He went on to receive cabozantinib alone, as is pretty standard in our practice these days. And then a year on cabozantinib, unfortunately, he developed a painful bone metastases. So I would suggest that in this setting, this might be a patient we consider for the lenvatinib belzutifan combination that we thought that we saw in LIGHTSPARK 011. Or we might be thinking if he's frailer, has been beat up multiple lines of treatment, maybe this is a patient that you're thinking about tivozanib alone or belzutifan alone, depending on how symptomatic they are.
Looking back when he started the cabozantinib, if he were to present at that point today, if you could, would you prefer to give lenvatinib belzutifan?
Certainly now that we have phase 3 data, it would be a consideration. And if the patient was hardier and able to tolerate the combination, you could certainly use it in the second line setting as well. Yes.
So Tian, Matt, and Rahul, I can't thank you enough. It's really been a great experience today. Audience, thank you for attending. Be safe, stay well, and have a great night. Thanks so much. Thanks so much, Tian, Matt, Rahul. Thank you.
Thank you.